Good morning, everyone, and welcome. I'm Dr. Asim Hussein, and I'm pleased to have the opportunity to speak with you today. We'll be exploring mitral stenosis, a fascinating and important topic in cardiology. This is our first slide, so I just want to give you a quick overview. Today, we'll cover what mitral stenosis is, its causes, symptoms, diagnosis, and treatment options. I look forward to guiding you through this presentation and sharing valuable insights. Let's get started. Let's look at this case carefully. We have a 36-year-old woman experiencing progressively worsening exertional dyspnea and orthopnea, which suggests she's having trouble breathing when she exercises and when lying down. She also has a history of rheumatic fever from childhood, which is an important clue. On examination, her apex beat is described as tapping, and there's a low-pitched mid-diastolic murmur at the apex with prosystolic accentuation. Now, these findings point us toward a specific type of heart valve problem. The tapping apex beat indicates increased atrial pressure or volume overload, and the low-pitched mid-diastolic murmur suggests turbulent blood flow through a narrowed mitral valve. The prosystolic accentuation typically occurs when the atrium contracts against a stiff or narrowed valve, which is characteristic of mitral stenosis. Given her history of rheumatic fever, which is a common cause of mitral stenosis, and the auscultation findings, the most likely diagnosis here is mitral stenosis. Remember, mitral stenosis often presents with these specific murmurs and symptoms related to pulmonary congestion and atrial pressure. So, connecting all these points, the correct answer to this question is C, mitral stenosis. Let's go over the key features that help us identify mitral stenosis. The correct answer here is C. Classic findings typically include a mid-diastolic murmur, which is heard during the relaxation phase of the heart when the mitral valve is open, but narrowed. You'll also often hear an opening snap, which is a sharp sound occurring shortly after the second heart sound, indicating the sudden opening of the stenotic valve. Additionally, a history of rheumatic fever is common because rheumatic carditis is a leading cause of mitral stenosis. Recognizing these features together helps us make a confident diagnosis. Remember, these findings are central to understanding mitral stenosis and its clinical presentation within the broader context of valvular heart disease. All right, let's take a look at this question. It asks us to identify the best explanation for the high risk of systemic embolism in a patient with severe mitral stenosis who develops atrial fibrillation. Now, the options listed are reduced left ventricular ejection fraction, left atrial dilatation and stasis, increased pulmonary venous pressure, mitral valve calcification, and right ventricular dysfunction. The key concept here is understanding how atrial fibrillation in the context of mitral stenosis leads to embolic risk. When the mitral valve is stenotic, the left atrium often becomes dilated because blood backs up and has difficulty moving through the narrowed valve. This dilation, combined with atrial fibrillation, causes blood to become stagnant in the atrium. Stasis of blood is particularly dangerous because it promotes clot formation. These clots can then dislodge and travel through the systemic circulation, potentially causing embolic events such as strokes. So, the most relevant mechanism explaining this high embolic risk is left atrial dilatation and stasis. It's the combination of structural change and abnormal rhythm that really increases the chance of clot formation and systemic embolism. This ties into the overall theme of how structural heart changes and arrhythmias can significantly impact embolic risk, especially in valvular disease like mitral stenosis. The correct answer here is B now. Let's delve into why that is. Mitral stenosis, as you know, is a narrowing of the mitral valve. This narrowing causes an increase in pressure in the left atrium, leading to its enlargement. When the left atrium enlarges, blood flow slows down and can become stagnant. This blood stasis is a key factor because it predisposes patients to atrial fibrillation, or AF, which is a common arrhythmia in these cases. Furthermore, this stasis and atrial enlargement increase the risk of thrombus formation, blood clots forming in the atrium. These clots can then embolize, leading to thromboembolism, which can cause strokes or other ischemic events. So, in summary, Mitral stenosis sets up a chain reaction. It enlarges the left atrium, causes blood to pool, predisposes to AF, and ultimately increases the risk of thromboembolism. Recognizing these connections is crucial for understanding how mitral stenosis impacts patient management and stroke prevention. Now, let's look at this question about echocardiography in a patient with mitral stenosis. The key measurement here is the mitral valve area, which is 0.9 square centimeters. This measurement helps us determine the severity of the stenosis. Remember, the classifications range from mild to critical, and each has specific criteria based on the valve area. A valve area greater than 1.5 cm2 is generally considered mild, while anything less than 1 cm2 tends to be severe. So, with a valve area of 0.9 cm2, we're looking at a severe level of mitral stenosis. It's important to connect this to our overall understanding that as the valve area decreases, the obstruction to blood flow increases, leading to more significant symptoms and potential complications. In this case, the correct classification would be severe, which highlights the importance of accurate measurement in guiding management decisions. The correct answer here is C now. Let's focus on how we assess the severity of mitral stenosis. The key measurement we look at is the mitral valve area. Mild stenosis is characterized by a valve area greater than 1.5 square centimeters. When the area decreases to between 1 and 1.5 square centimeters, we're dealing with moderate stenosis. And if the area is less than 1 square centimeter, that indicates severe mitral stenosis. Understanding these thresholds is crucial because they help guide our management decisions and predict potential symptoms or complications. Remember, the smaller the valve area, the more significant the restriction of blood flow through the mitral valve, which can lead to increased pressures in the left atrium and pulmonary circulation. This classification really ties into the overall theme of assessing and managing valvular heart diseases effectively. All right, let's walk through this question carefully. We have a woman with known mitral stenosis who suddenly develops pulmonary edema, which is a sign of acute heart failure. She also has a fever and a fast, irregular pulse. These clues are quite important. Mitral stenosis causes a narrowing of the mitral valve, which impairs blood flow from the left atrium to the left ventricle. If she develops a sudden pulmonary edema, it suggests that her left atrial pressure has increased abruptly, leading to fluid backing up into the lungs. Now, the presence of fever and irregular pulse raises suspicion of an infection affecting the heart, specifically infective endocarditis. Infective endocarditis can cause damage to the valve apparatus, leading to acute valvular dysfunction. Given her history of mitral stenosis, if infective endocarditis affects the mitral valve, it can cause an acute worsening of stenosis or even valve destruction, precipitating pulmonary edema rapidly. So, considering all these points, the most likely precipitating factor in this scenario is infective endocarditis. It explains the sudden deterioration, fever, and irregular pulse, and ties into the overall theme of how infections can acutely worsen pre-existing valvular disease. All right, let's look at the correct answer here, which is C. So, what's happening in atrial fibrillation is that there's a loss of effective atrial contraction, and along with that, patients often experience tachycardia. These changes cause a significant increase in left atrial pressure, and when the pressure in the left atrium rises sharply, it can lead to flash pulmonary edema, especially in the context of mitral stenosis. This is a crucial point because it highlights how arrhythmias like AF can dramatically worsen the hemodynamics in mitral stenosis, leading to sudden pulmonary complications. Understanding this connection really underscores the importance of managing atrial fibrillation carefully in these patients to prevent such acute events. Let's look at this clinical scenario. A patient with severe mitral stenosis presenting with acute pulmonary edema and atrial fibrillation, with a ventricular rate of 150 beats per minute. Now, this is a critical situation that requires prompt management. The key here is to stabilize the patient quickly and effectively. In such cases, we need to control the heart rate to reduce the symptoms and prevent further hemodynamic deterioration. Rapid ventricular rates can worsen pulmonary edema and compromise cardiac output in these patients. So, among the options provided, the most appropriate immediate management is rate control, typically with a beta blocker, possibly combined with diuretics if there's fluid overload. This approach helps slow down the ventricular response, relieve symptoms, and stabilize the patient. Other options like aggressive IV fluids or nitrates alone aren't suitable here because they could worsen pulmonary congestion. Electrical cardioversion might be indicated later if rhythm control is necessary, but in the acute setting, rate control is the priority. And initiating an ACE inhibitor could be part of longer-term management, but isn't the immediate step in this emergency. So the main takeaway is that in this scenario, the best immediate action is rate control with a beta blocker, possibly alongside diuretics, to manage the acute pulmonary edema and rapid AF. Let's take a closer look at the correct answer, which is the key principles here are quite important for managing this condition effectively. First, we want to slow the heart rate, because a faster heart rate can worsen symptoms and strain the heart. Second, reducing pulmonary congestion is crucial, as it helps relieve symptoms like shortness of breath and prevents further fluid buildup. And third, optimizing preload is essential to ensure the heart is filling properly, without becoming overstretched. Remember, rate control is absolutely critical in this context. By focusing on these principles, slowing the heart rate, alleviating pulmonary congestion, and fine-tuning preload, we can improve patient outcomes significantly. These strategies are all interconnected and play a vital role in the overall management plan. Let's consider this case. A 44-year-old woman with mitral stenosis who remains in sinus rhythm. The key question here is, when should we consider long-term anticoagulation for her? Looking at the options, the most important thing to remember is that anticoagulation isn't automatically indicated for all patients with mitral stenosis. Instead, we focus on specific risk factors that increase the chance of thromboembolic events. Option A suggests anticoagulation only if the ejection fraction is less than 40%. But, in this case, her ejection fraction isn't mentioned as an issue, so that's not the main criterion here. Option B states only if the valve area is less than 1 centimeter squared. While severe stenosis can increase risk, the decision for anticoagulation involves more than just the valve area, especially if she remains in sinus rhythm. Option C says in all mitral stenosis patients, regardless of rhythm or other factors. But actually, not all patients need lifelong anticoagulation. It's more targeted. Option D points to patients with mitral stenosis who also have atrial fibrillation, prior embolism, or a left atrial thrombus. These are well-established risk factors that significantly raise thromboembolic risk, making long-term anticoagulation clearly indicated. And finally, option E suggests only after valve replacement. While anticoagulation is common post-replacement, this question is about her current status, not post-surgical management. So the most accurate answer here is D. Long-term anticoagulation is indicated in patients with mitral stenosis who have atrial fibrillation, previous embolic events, or a left atrial thrombus. These factors significantly increase the risk and guide us toward anticoagulation, even if she's currently in sinus rhythm. Understanding these nuances helps us tailor our approach to each patient's individual risk profile, which is a core theme in managing valvular heart disease effectively. Let's focus on the correct answer, which is D. When it comes to managing mitral stenosis, anticoagulation plays a crucial role, especially in certain high-risk scenarios. Even if the patient's sinus rhythm is restored, anticoagulation remains mandatory if they have atrial fibrillation, a history of prior embolism, or a left atrial thrombus. These conditions significantly increase the risk of thromboembolic events, so we need to ensure proper anticoagulation to prevent potential strokes or other complications. This highlights an important point in our overall discussion, that managing mitral stenosis isn't just about the valve itself, but also about addressing the associated risks of clot formation and embolism, which can be life-threatening. Let's look at this question about a 39-year-old woman with severe symptomatic mitral stenosis. She has pliable, non-calcified leaflets and no left atrial thrombus. So, what's the best definitive treatment for her? First, it's important to recognize that her mitral stenosis is likely rheumatic in origin, given her age and the description of non-calcified, pliable leaflets. Now, among the options, mitral valve replacement is a common definitive treatment, especially in cases where the valve is severely stenotic and symptomatic. Balloon mitral valvotomy, or balloon valvuloplasty, is usually preferred in younger patients with favorable valve morphology, pliable, non-calcified leaflets, as in this case, because it's less invasive and preserves the valve. Long-term diuretics are only supportive. They don't address the underlying stenosis. ACE inhibitors help with symptoms in some heart failure cases, but don't correct the mechanical obstruction of the mitral valve. Surgical commissurotomy is an option, but it's more invasive and typically reserved for cases where balloon valvuloplasty isn't suitable, especially in elderly patients or those with calcified or fused leaflets. So, putting it all together, for this young woman with favorable valve anatomy, the preferred definitive treatment would be balloon mitral valvotomy. This approach offers effective relief of stenosis with a lower risk profile, making it the best choice here. The correct answer here is B. Percutaneous balloon mitral valvotomy, or PBMV, is actually considered the first-line treatment option for patients who have suitable valve anatomy. Now, it's important to remember that this approach works best when there's no significant mitral regurgitation or the presence of thrombus. When those conditions are absent, PBMV offers a less invasive alternative with good outcomes. This ties into our overall theme of tailoring interventions based on patient-specific anatomy and risk factors, ensuring we choose the safest and most effective option for each individual. Now, let's consider this scenario. A pregnant woman with known mitral stenosis starts experiencing worsening dyspnea during her second trimester. The question here is, what physiological change is responsible for this deterioration? Looking at the options, the answer that best explains this is increased heart rate and blood volume. During pregnancy, the body naturally adapts by increasing blood volume and cardiac output to meet the needs of both mother and fetus. However, in the case of mitral stenosis, these changes can place additional stress on the heart. The narrowed mitral valve makes it harder for blood to flow from the left atrium to the left ventricle. So, when blood volume and heart rate increase, it leads to increased pressure in the atrium, causing pulmonary congestion and dyspnea. This highlights a key point. The physiological adaptations of pregnancy, while normal, can exacerbate certain cardiac conditions like mitral stenosis. Understanding these changes is crucial for managing pregnant patients with heart disease effectively. The correct answer here is B. Now, let's discuss why. During pregnancy, there are significant cardiovascular changes. Blood volume increases substantially, which is a normal adaptation to support the developing fetus. Heart rate also tends to go up to meet the increased metabolic demands. These changes, however, have some implications, especially for conditions like mitral stenosis. The increased blood volume and heart rate lead to a shortening of diastole, which is the phase when the heart fills with blood. Shortening diastole means less time for the heart to fill properly, and in patients with mitral stenosis, this can worsen the obstruction. Essentially, pregnancy exacerbates the hemodynamic burden on the heart, making management more challenging. This connection highlights the importance of understanding how pregnancy impacts cardiac conditions and tailoring our approach accordingly. Let's take a look at this overview. Most of these conditions are almost always rheumatic in origin. When there's an obstruction to the left ventricular inflow, it causes an increase in left atrial pressure. This, in turn, leads to pulmonary congestion, which can cause symptoms like shortness of breath. Specifically, we're focusing on mitral stenosis here. That's a narrowing of the mitral valve, and it's a classic example of how rheumatic heart disease can impact cardiac function. By understanding this process, we can see how the initial problem in the valve can cascade into larger issues affecting the lungs and overall heart performance. Let's take a closer look at some of the key clinical features associated with this condition. First, patients often experience exertional dyspnea and orthopnea, which means they have difficulty breathing during physical activity or when lying down. These symptoms are indicative of underlying cardiac or pulmonary issues that worsen with exertion or body position. Hemoptysis, or coughing up blood, can also occur and signals that there might be bleeding within the lungs or pulmonary vasculature, often due to increased pressure or damage. Atrial fibrillation is another common feature, and it's important because it can lead to irregular heartbeats, which increase the risk of blood clots forming in the atria. These clots can then travel through the bloodstream and cause strokes or systemic embolisms, making atrial fibrillation not just a rhythm issue, but a significant risk factor for more severe complications. Now tying this back to mitral stenosis, which is a narrowing of the mitral valve, all these features, dyspnea, hemoptysis, atrial fibrillation, and embolic events, are interconnected. Mitral stenosis leads to increased pressure in the left atrium, which can cause atrial dilation and promote atrial fibrillation. This cascade explains why patients with mitral stenosis often present with these characteristic clinical features. Recognizing these signs is crucial for early diagnosis and management to prevent serious outcomes. Let's talk about the examination findings for mitral stenosis. First, you'll often hear a loud S1, which makes sense because the mitral valve is closing forcefully due to the narrowed opening. You might also notice an opening snap, and the timing of this snap is important. If it occurs earlier in diastole, it indicates more severe stenosis. Additionally, during auscultation, you may hear a mid-diastolic murmur at the apex of the heart. This murmur results from turbulent blood flow across the narrowed mitral valve during diastole. Connecting this to the overall picture, these examination signs help us confirm the diagnosis of mitral stenosis and assess its severity. Recognizing these clues is key in understanding the hemodynamic impact of the condition. Let's take a closer look at the diagnostic approach for mitral stenosis. First, echocardiography is essential. It helps us evaluate the valve area and the pressure gradients across the mitral valve. It also allows us to assess the size of the left atrium, which often enlarges in response to the increased pressure. Moving on to the ECG, we typically see atrial fibrillation, which is common in these patients, and often there's evidence of left atrial enlargement. Lastly, the chest X-ray can provide clues, such as a straight left heart border, which suggests left atrial dilation. Putting all these together, these diagnostic tools help us confirm mitral stenosis and understand its severity and impact on the heart. Let's talk about management strategies for mitral stenosis. First, rate control is crucial, and we often use medications like beta blockers or diltiazem to help keep the heart rate in check. This reduces symptoms and improves cardiac function. Next, diuretics are important for managing congestion. They help relieve pulmonary and systemic fluid buildup, making patients more comfortable. Anticoagulation should be considered when indicated, especially if there's atrial fibrillation or other risk factors for thromboembolism. Preventing clots is essential in these cases. When it comes to definitive treatment, balloon valvotomy is a good option if the patient's anatomy is suitable. It's a minimally invasive way to open up the narrowed valve. If balloon valvotomy isn't appropriate, then surgical intervention becomes necessary. This could involve valve repair or replacement, depending on the severity and the patient's overall health. Overall, managing mitral stenosis involves a combination of symptom control and addressing the underlying valve issue, tailored to each patient's specific situation. Let's go over some key pearls for mitral stenosis. First, if a patient has mitral stenosis and atrial fibrillation, anticoagulation is essential to prevent thromboembolic events. Next, in cases of acute pulmonary edema, always think about atrial fibrillation as a potential underlying cause, since it can precipitate pulmonary congestion. When it comes to pregnancy, it can actually worsen mitral stenosis because of the increased blood volume and cardiac workload during pregnancy. So, it's something to monitor closely. Now, regarding severity, remember that it's primarily determined by the valve area, not how loud the murmur sounds. A quiet murmur doesn't necessarily mean mild disease. And finally, an important clinical sign. The opening snap occurs closer to S2 in severe mitral stenosis. This indicates a very narrowed valve, making the opening snap occur earlier in diastole. All of these points are crucial in understanding and managing mitral stenosis effectively. Thank you so much for your time and attention today. I really appreciate your engagement and interest in the topics we've discussed. I hope you found the information valuable and that it helps you in your own work or projects. Remember, the key points we covered, whether it's the importance of innovation, collaboration, or continuous learning, are all essential for success in our field. I encourage you to take these ideas forward and apply them in practical ways. Once again, thank you for being such a great audience. I look forward to seeing how you implement these concepts in your endeavors. Have a wonderful day.